And we're live. Hey people, how you doing? Welcome to episode 266 of the Sports Therapy Association podcast. My name is Matt Phillips, creator of OneShotLive.com, and as always, this episode is being recorded live on the Sports Therapy Association YouTube channel and Facebook on a Tuesday night at 8 o'clock. So, should sports therapists be allowed to diagnose? It's a question that often causes much debate. For example, in a panel debate that took recently at Therapy Expo at the NEC in Birmingham. And despite sports therapists being trained to assess and identify the cause of a musculoskeletal injury, some would argue that the giving of a formal diagnosis should be the role of a GP or an allied health professional like a physiotherapist, an osteopath, podiatrist or chiropractor. So to discuss this topic and share their views, I'm very shortly going to be joined by Anna Maria Mazzieri, Director of the ST School, and Gary Benson, Founder of the Sports Therapy Association. If you have managed to join us for this live recording, then do please feel free to add your thoughts in the comments section, whether you're on Facebook or YouTube. For example, I can see now that Sarah Jones has joined us. That means I can bring her comment up onto the screen, and Sarah says, "Evening, actually on time for once." Sarah, you're always on time. You're perfect. There we go. Also, Imi's here as well. Fantastic crowd already coming through the door. So yeah, if you're here, this is your time to have your say. We really want to hear from you the same way as the idea at Therapy Expo, as we heard from you as well. So yeah, do please speak your mind. And if you are listening to the podcast, then thank you very much. Please leave a liking and a review just to help us out. And if you do have a comment or a question, then best thing probably is to go to YouTube, Sports Therapy Association YouTube channel, and leave your thoughts in the comments there. And we do monitor it and we will respond to that. Right. Let's get the discussion going. There's lovely more people coming through for the live. Thank you everyone who does join us live. We really appreciate it. It's amazing to see you giving up your time to contribute to this, so I do appreciate it. Right, let's get the discussion going. Should sports therapists be allowed to diagnose? With tonight's special guests, Anna Maria Mazzieri, Director of the ST School, and Gary Benson, Founder of the Sports Therapy Association. Hello. How are you doing?
Good evening.
That was Gary.
Yeah, good evening.
And there with the lighter, more dulcet tones was Anna Maria Mazzieri. Cool. Fantastic. Right then, so for people who don't know you both, which I'm always hoping, obviously, there are people particularly downloading it. Anna Maria Mazzieri, would it be possible to give us a brief summary of who you are, what you do within our industry?
So tonight I'm wearing my graduate sports therapist hat. But I say that because usually I actually identify myself as a soft tissue therapist and massage therapist, but I'm actually a graduate sports therapist, and I'm very passionate about the industry. Who am I? I am a practitioner. I'm a full-time clinician, but also an educator with the ST School, which is a training provider which I created. This is a vocational training provider for vocational courses, which I'm a strong advocate for. Thank you.
Fantastic. Great to have you along. That was incredibly succinct. I'll tell you what, 2026 is going to be the year. I'm amazed so far. Gary Benson, for people who don't know you, get a little introduction of who you are and what you do.
Yeah, so as you mentioned, Matt, I'm the founder of the STA. I've represented members in various roles within the industry for 18 years now. I was, going back to that time, I was part of the General Council for Massage Therapists. Had a couple of years there. I was a profession-specific board advisor to one of the first voluntary regulators, the CNHC. I've been sports therapy advisor to a couple of other industry stakeholders, if you like, and I had another role within the industry. I just felt that there needed to be more support. A membership association, in my opinion, shouldn't be linked to a training provider. I think that's a conflict of interest. So I thought, how can we be better? How can we support members better? And here we are today, 266 episodes since COVID, supporting members and the wider industry.
Fantastic. Thanks, Gary. Right, I'm really excited to have both of you here. I'm really looking forward to this discussion. It's kind of like I mentioned in the introduction, a continuation of a discussion or presentation or discussion here that was started at Therapy Expo. I've also got to say thank you very much to everyone again who's joined us live. We've got loads of people. There's something going on, something in the water. Maybe it's Anna Maria has attracted you all, so it's fantastic. But as you're here, all of you, do please leave some comments. It's so useful for us as educators and for example, Anna Maria, director of the ST School, and Gary Benson, the founder of Sports Therapy Association, just to hear your comments, just to hear what you feel and what you know and what you don't know and that sort of stuff. So do please provide us with your experience and skills. We'd love to know that. Talking of that, so the title of this episode, should sports therapists be allowed to diagnose? To get things going, maybe let's take that in order. Can we define first of all what a sports therapist is?
Well, we had a very good and honest collaborative panel discussion at Therapy Expo with Sarah Catlow from the Sports Therapy Organisation, Dr. Chris Holland, who's the chair of the board of the Society of Sports Therapists, and myself, not as academically recognised as my two panel colleagues. But there was a kind of an argument, if you like, that a sports therapist has a minimum standard of education, which has to be a graduate qualification. I took an opposing view that people who trained in the 80s, the 90s and the noughties, where diplomas, advanced diplomas from the likes of the International Institute of Sports Therapy, from Rayworth College, from other training providers who are no longer with us, but they had valid diploma vocational qualification. So at present, we're in an unregulated industry, and as such, there is no minimum standard of education. I went on to explain that what differentiates a sports therapist from a soft tissue therapist are what we call the national occupational competencies, the national occupational standards, which are held usually by Skills for Health, the sports therapy ones, and soft tissue therapists are currently held. The NOS is currently held by the Complementary Natural Healthcare Council, of which there are two. A sports therapist, they are 14 competencies. So there's a difference there, a mathematical difference of 12 competencies. But in an unprotected title industry, anyone can call themselves a sports therapist. What we do at the STA is we issue membership categories and certification based on the wording of the qualification. If it's a diploma in soft tissue therapy, it will say that on their certificate. If it's a degree in sports therapy or a degree in sports rehabilitation, it will say that on their membership category. And that then, we think, explains their title and their scope of practice.
Fantastic. Thanks for clarifying that, Gary. So for some, the problem with the question is anybody can use the title sports therapist. When we're talking about are sports therapists allowed to diagnose, or should they be allowed to diagnose, it kind of is understandable why some people see, and we had this at Therapy Expo, that the answer is regulate the title. Only people who do a certain type of qualification should be allowed to call themselves sports therapists. But just to get that one out of the way, because that's what probably a lot of listeners are thinking, that holds its problems as well, doesn't it?
Well, I think the issue here is that sports therapy is a very small industry, 35 years old, really. If we look at the total number of therapists who are registered with a stakeholder, it's somewhere between 5,000 and 6,000, and that includes the less than 100 registered with the Complementary Natural Healthcare Council. I don't know if anybody saw social media, but the FHT have just recently put out an offer of 50% off only for sports therapists. They then said that as long as you've got a level 3 qualification, then you qualify. But that's missing the whole point of what we're trying to decide as a sports therapist. If we're putting the bar so low that anybody can jump over it, there are no standards. The race is to the bottom. So what we're advocating now is that the professional associations have a robust eligibility criteria, and I issued a statement last week saying that I wouldn't accept certain qualifications or CPD simply because the standard had become so low. And I'm audited on that, so it was my decision to put that out there, and I've got some really good feedback to say, we should be stronger. A professional association should be stronger and say this is not fit for purpose. Please don't waste your money.
Okay, that's cool. So although the government isn't regulating the title, if professional associations in theory do their jobs, then they can regulate it and make sure that no one's kind of working outside of their scope. Anna Maria, you there were kind of nodding your head and shaking your head at various moments.
Yeah, I'm quite, as you know, I am quite expressive. Matt, you hit the nail in the head. If we have more professional associations like the STA, we don't need regulation. If actually the industry it's well voluntary regulated, we don't need state regulation that, as we know, comes with quite a lot of adds-on that we might not like. The problem is that, like Gary said, the FHT just released that message, that it really shows how little they know about the industry. So we have those people that they are claiming to represent professionals in general, not only, but actually, what do they know about the industry? Because they say actually it's open to sports therapists, but from level 3, they're not. There is not even care about progressing the industry. Nothing wrong with level 3 therapists, but we're talking here about a profession with national occupational standards, which the level 3 therapist will not have. So to me, there seems like to be a mismatch between the people that runs those professional associations and their understanding of what really happens at the level. I must say, Gary, I was sitting there with a physiotherapist, and you're sitting next to a physiotherapist, and you're at the panel, at the diagnosis panel, and both of us, we kept saying, every time you said something, we said, you just making so much, because you said, oh, I don't have the academic credential of the other people, but you were the one, and both of us, me and this physiotherapist, let's say we're quite old, so, but actually what you were saying were reflecting exactly what the industry is, but also you're progressive because you're reflecting where you think realistically and progressively where the industry should be. So actually, I was really proud to be a member of the STA, and I say that all the time. But in that particular case, I thought you held up really well, because you really represented the reality who we are and celebrated who we are. So thank
I
you.
think some of the things that, if we take a snapshot of the industry, the SST represent the graduate members. Historically, they used to represent foundation degrees. I think it was in 2014 they issued a statement saying they would no longer represent FDSCs or a 2+1 degree, and yet there was a 20-day diploma and a 10-day distance learning diploma that led to membership. So there's some conflicts there. But if you look at the number of sports therapists, in our membership, yes, we've got some graduate members, but we've also got some uniquely skilled, experienced, mature therapists who haven't gone to university. And Dr. Chris Holland was extolling the benefits of, taking the 18-year-old, straight from college, giving them 3 years worth of life experience and building them into that, robust graduate sports therapist. My argument was that somebody who's got 3 years life experience between the ages of 18 and 21 doesn't match the skills that we as experienced therapists, as vocationally trained therapists, I did go on to do academic qualifications, later in life, but I didn't really feel any benefit from those. So the skills that we built up, how to listen, how to communicate, how to validate, how to encourage, how to motivate, how to educate our clients, they're the requisite skills that I think we need, not the passive intervention training that is commercially sort of driven by the industry. So, if we look at, the reason for this is, should we diagnose? And the answer, if we Google, and you're going to come on to that later, Matt, is we should be a regulated profession. If we look at the history of the applications for regulation, it's failed 3 times, even though it's been recommended by HCPC to the Secretary of State to regulate the industry. 3 government white papers in 2010, Enabling Excellence, 2017, Reforming Regulation, and 2021, which was something along the lines of, I forget, it's a Health and Care Act. They've all said that regulation is not fit for purpose in its current guise. The estimated cost in 2010 for regulating a new industry was between 3 and 5 million. In 2023-24, it was estimated between 10 and 15 million, and that's just the machinery of government. There are £6.8 billion is spent annually across regulation across the whole of the industries. We're in a crisis at the moment. We need to be saving money, and I don't think having 5,000 or 6,000 registered sports therapists and probably the same number who are not members of any association, I don't think we can afford it. Even if we could, what does it look like? What does the HCPC model look like for sports therapy, which incidentally was taken off the aspirant list in 2015? Nobody's shown us that. So we're comparing apples against pears. We need to know what it's going to look like, and then we can make an informed decision whether to pursue that or not.
Yeah, and I want to pick up a moment to what you said about the comment that was made in the panel about, yes, we can diagnose because our students go through 3 years of, this month of hours of academic study, and there is great value in university. I love university. I'm academic, so I have no problem. But there is a certain amount of people. Yeah, they might be very good for those people, but where is the value on, why don't we put value on people that might come as a second career? They already come to, I say me as a vocational educator, they already come with the richness and the depth of critical thinking from life. They don't have, they might not have the academic knowledge, but they're gaining it slowly, but they have all the other knowledge that the 20-year-old, 22-year-old might not necessarily have when they start university. So this is where we are still, again, a bit on the bonnet between this university and vocational, that I do really believe that in this country we see vocational in a very different way than that, for example, that in Europe this year, because vocational learning, it's quite highly regarded in Europe, not as a less good, as a different learning. And Gary, you just said it really well. Actually, instead of having the training within the 3 or 4 years altogether, while between 20 and 24, whatever the age is, a vocational therapist have it over 10 years. But the beauty of it, actually, they doing it. They have also the time to practice and to live that learning. One thing that certainly we can improve, certainly, is that eventually we could do with having let's say, assessing that learning, because going to CPDs, some people might do great CPDs and brilliant, but the difference is they are not assessed. So I do think, and maybe Gary, little bit, I put in a little bit, I see something there for you. Maybe every few years there could be an assessment, a professional association level, to assess the knowledge of those therapies against some learning outcomes.
If we look at the National Occupational Standards, then, which are at the moment a decade out of date, the collaborative discussions we've been having is to update those, and all of the stakeholders want to be involved in that process. But if we look at a lot of the current NOS, which are held by the Sector Skills Council, Skills for Health. Now, a lot of those are what I would regard as low-risk modalities. Mm-hmm. So if it's kinesiology taping, or taping and strapping, now that really can be learnt, in a variety of ways. And because it's a low-risk modality, I don't see much value in having a formal assessment of competence.
I agree.
If it's a high-risk modality, like, piercing the skin with needles or manipulations, then there has to be an assessment of competency, and the training providers then, instead of dodging the bullet as they do at the moment by issuing certificates of attendance, should be issuing certificates of competency. Yeah. So I think there is going to be progress on this, but it's around about how do we categorize, and the best way to categorize is speak to the insurance underwriters who manage the risk.
Yeah, so I would say I see it also a little bit, what I was saying about maybe the professional association could do some assessments, not for modalities, for literally knowledge. So, for example, in order, so because we just said that we want the sports therapists to all have the same critical thinking knowledge and theoretical knowledge than those ones that go at university, so that we are all, we're all the same, we're all considered the same. And I will say that actually, for example, communication skills or the theory of healthcare, principle of healthcare, things like that, people find it difficult to cover them on CPDs because, and actually those are very, very valuable. And that's what I think, maybe every few years there could be somewhere somewhere at the governance level where the non-university trained therapist can actually have their knowledge assessed, so they can say, actually, I have my knowledge. It's not about modalities, the theory behind, I don't know, the theory behind MSK injuries or things like that, so that so that finally they're not considered any less than the university students.
If we look at the model from HCPC for their audit and their CPD, you've only got to go on social media and see how much anxiety that invokes in therapists. Now, I'm going to be devil's advocate. I'm not agreeing or disagreeing.
No, I'm very, very happy to.
What I would say is that by introducing, and some of the associations do have a test, okay, which is taken every so often, that is a barrier to people remaining as members. Now, if I can encourage people to stay as members, we can support them. We can present them with, as the evidence base changes, we can filter that information through. If somebody chooses not to be a member of an association because there's that extra barrier of a test, then we lose those people and they go into the shadows of the industry, and half of the people working in the industry are not members of associations. That's my estimate. They still might be doing really aggressive treatments with handlebars and instrument assisted, because they haven't kept up to date as the narrative and the evidence has changed to support the application of those modalities. So it's easier to police people when they are, members of an association than it is to let them ride wild.
Yeah, maybe not a professional. Yeah, you're right, actually, Gary. I haven't thought about all of that, but maybe not professional association. But I do think that one of the ways to match the two between university and vocational is that when because people that have been in the industry for 20 years, they've done plenty of really good CPD courses. They might not have done, they going to the having a degree. But so there has to be somewhere where their knowledge is assessed. You see, that's why
we do the with our CPD forms now. It has the a description of the learning. It has the learning outcomes, but it also has a reflection on those outcomes. So we're looking at higher level, skills to be able to reflect on whether those learning outcomes are beneficial to or work against what their biases are or what they're doing in clinical practice. And we tried to make that reflective practice thing, as you did at the Hands-On Hub and the STA conference. We tried to make that reflective practice part of the sort of policy, so that it puts us level with the HCPC model of reflective practice. And they are skills that they are developing at university, albeit at a younger age. And my argument in that panel discussion was, I'm going to say no, we shouldn't diagnose, and I'm going to try and justify why. They were going to say yes, and they were going to try and justify why. And that's a well reasoned and balanced debate, and I thought it was a really successful debate as well.
Well, I'm just going to jump in for a second. For the listeners, I think this is really important, because the most common, like we said before, the most common answer to should sports therapists be allowed to diagnose is, as long as they're graduates, because they've been to university and therefore they've got all the experience and they're the same as a physio and they can do it. And it's more complicated than that for the reason we've discussed. So I think to really find a solution for this, we need to understand the barriers to just following that path of logic. That is not the answer. There's an awful lot of people out there who you'd be eliminating a lot of amazing people out there who could work in healthcare who haven't been to university when they're younger, who it's not appropriate now to go 4 days a week or something. They've got kids, they've got elderly people looking after. Yeah,
privilege.
So we've got to find out a different system. And that's why we spent kind of nearly half an hour clearing that up. And I'd like to say that Kate Williams, who's the head of education for the SST, Society of Sports Therapists, she is going to come on the show after the new year. We wanted to get one for this one, but just too busy after Therapy Expo. But yeah, we appreciate the reply from that. And it was really nice getting that reply, because I think we all agreed after Therapy Expo that there was a exciting theme of collaboration. The fact that you guys with the STO, the STA, and the SST were on this stage together physically, discussing things politely and realizing we've probably got more in common here than different, was a real step forwards. And I just want listeners to appreciate that and realize that thanks to a lot of work, I mean, I'm biased, a lot of work that Gary's been doing, but I'm sure other people have as well, and Anna Maria, we are getting closer to having these important discussions and finding solutions which look after everybody. So it's good. 2026 is going to be a very positive year, I think, and I'm the biggest cynic and skeptical it is, but I'm really excited about 2026 for our industry. So I want to move on now. Let's imagine a sports therapist we do have a way of making sure they've got the right criteria in the education and the reasoning skills. We move on to now whether they should be allowed to diagnose. Now, one of the things that came out from Therapy Expo, which I was surprised at, I think we all kind of went, really, was this idea that diagnosis and to diagnose is not a protected word. The only way you can get wrong is you start basically pretending to be have a professional title that you haven't got and you're working outside of your scope. If you're doing that and you use the word diagnosis, then you're going to get into terrible trouble and it's illegal. But to actually say, oh, I diagnose it as this, technically is not protected. This is still to be debated, isn't it? As far as I know, I'm still not that clear yet.
No, and during the talk when the legal representative said that, I did a quick reflection and thought, well, it doesn't match what I've been Googling over the past 2 weeks in preparation for that panel talk. But I said that it would become part of my reflective practice to look at that in more detail. Like the SST, I haven't had capacity to do it, still on my notebook, because we've been so busy since Therapy Expo. But if we Google, who can diagnose, and you've got the screens there to show, Matt, it's limited to regulated health professions.
Yeah, let's have a little look at that, because now I understand, I'm hoping that people who are watching this are going, hold on, this is just Copilot, this is just AI, but I think it's important because this is what the results people will get when they do Google this. So for example, I'm just going to read this out for people listening to the podcast. So this was a Copilot search. Other forms of AI are available, and it said the word diagnose is a protected title in certain contexts, particularly in the UK. The term is associated with regulated professions such as medical practitioners, and its use is restricted to those who are registered with the appropriate regulatory body. The Medical Act 1983 protects titles like diagnose and requires individuals to be registered to use them. So when you do an AI search, it does give you links to where the information comes from, which is useful. I recommend you have a look at those and click on them. And this actually used information. It's not a direct quote from the HCPC, but it used information provided by the hpc.uk.org in a post they would put about who we regulate the professional. But I went on to look at this, and it seems to me that it's not clear at all. Sometimes it says that you need to, sports therapists can have a working diagnosis, and that seems to be okay, like the terminology, but not a medical diagnosis. But then it started getting confusing because there was something, it says here, conditions such as fractures or dislocations need to be diagnosed by healthcare providers like doctors or physiotherapists. But I would have thought something like a fracture wasn't like, it's not as there's more difficult diagnoses than that. I can understand people are worried about. You can form a diagnosis, then get it checked, definitely, and you're not 100% sure until you've seen it on that X-ray or something has been. You form the hypothesis.
So, there is a difference also between medical diagnosis and clinical diagnosis. So the medical diagnosis is exactly what you say. The diagnosis that can become from a medical practitioner, and that is, autoimmune diseases and so on. A clinical diagnosis is a diagnosis that comes from, assessing, like what you call the working diagnosis. So that's different. But certainly the term diagnosis from the Medical Act is protected. I researched that because we're having the same discussions in Italy between the physiotherapist and the physiatrist. The physiatrists are medical doctors, the medical doctors that focus on MSK, or specialists in MSK, and physiotherapists. Physiotherapists in Italy, they don't diagnose. They assess. They have their working diagnosis, and because it's enough for them to if it's enough for them to treat at the best, and then anything that is beyond that, if there is anything that changes the treatment plan, then it means that they have to refer anyway. So what is the function of the diagnosis from that perspective? Why do they need to diagnose when actually you got the clinical the working diagnosis, where you're assessing, you're checking if there are red flags, you're checking if there is any contraindication, you're checking if it's something that your treatment, your approach is the best suited for. And if it's not, then refer for that more specific diagnosis. But personally, I do not think. But there are different. So there is the term medical diagnosis and clinical diagnosis. They're all regulated by the Medical Act, like you said, 1983. I checked before we went to the panel. So that's why I was quite shocked when they said it's not protected. It is illegal in this country. It's legal that it's health professionals.
It's strange because, yeah, if you use the word medical diagnosis, so if a sports therapist for some reason said, "Oh yes, I'm going to give you a medical diagnosis now that you've got this," then we can discuss whether it's worth using that word. But that would be wrong because you haven't got that. You haven't got the skills. It's outside of your scope. So I think the problem is whether you're working outside your scope. If you make a diagnosis and you use the word diagnosis, and then it can be argued in court that you are actually diagnosing something that's not in your scope, and it could be argued that you don't know if it's definitely a fracture until you've actually had it x-rayed and you've seen it and you're as close to proof as possible, then you shouldn't be using that word. But it's an interesting one. Gary, what have you found on the term diagnosis? Not should we use it or not, but is it
so what I did before the panel is I just Googled who can diagnose, and admittedly you get the AI version. So I read through that, and then I went into the links that it provided for me, and it said that only, and the word I used to describe it was the diagnosis is the preserve of allied health professions. Now, if you look at the HCPC, it recognises and regulates 14 professions in England, Scotland, Ireland, and 13 in Wales. Underneath that, above that, in a sort of hierarchical sort of pattern, is the Professional Standards Authority, who oversee the HCPC, but they also oversee the likes of the General Osteopathic Council, the Chiropractic Council, etc., etc. So, sports therapy was not even mentioned in there. And I know that one of the stakeholder website clearly defines their members as allied health professions, albeit in lowercase. But I remember during COVID that, whilst we were taking lots of legal and lots of health and safety guidance before issuing, support to our members, some of the stakeholder issuing statements like, if you've done our qualifications, you regard it as medical, and therefore you don't have to go into lockdown. I challenged those, and they then had to, rather embarrassingly for the industry, had to retract those statements. So, I like the term clinical reasoning, and what we're doing, and my industry colleague Yvonne Blake from the Sports Massage Association, she gave a talk straight after our panel discussion, which I couldn't make because I was still involved in this discussion outside with the wider public who were there. And she talked about differential diagnosis, which is a process of ruling things out rather than ruling things in. my argument has always been, when I was in clinical practice, that if I say to somebody, oh, you've got a sore heel, it de-escalates their symptoms from being told they've got plantar fasciitis, because if you Google plantar fasciitis, the first thing that comes up is, oh, you're going to have 18 months worth of intolerable pain and nothing will fix it. But if we say we've got a sore heel and we work through, a progressive treatment plan, then I think we've de-escalated their symptoms. We've not, we've not used Dr. Google, and therefore I think that's better for the client.
Sounds good. Makes sense. Yeah. It's true what you say. I think sometimes people want to use the word diagnose because it makes them feel more empowered. It makes them feel that they are closer to the people who they put on a pedestal. And we'll probably discuss soon that that's part of the problem, because you shouldn't be putting others on a pedestal. You should be proud of what you're doing and not feel the need to use words like diagnosis. It's just going to get you in hot water. Because if you're using it to kind of subconsciously pretend to be something you're not, that's where you can get into trouble, and you've got to kind of consider how you're working. There was also an interesting thing which I read online suggesting that, where was this, about graduates? Even AI suggested that, here we go. The ability to diagnose can vary depending on the specific training and qualifications of the sports therapist. Graduate sports therapists who are members of professional organisations, that annoyed me. AI thinks that to be a member of a professional organisation, you need to be a graduate. So something's gone wrong there. May have more extensive training. That annoyed me as well. That allows them to assess and manage injuries effectively. That really annoyed me. But they still operate within a framework that does not include formal diagnosis. So watch out for the argument that if you're a graduate, you can use the word diagnosis, because you might find yourself again in hot water, particularly if you're insinuating that you're doing a medical diagnosis.
But what that does there, Matt, that excludes graduate sports therapists who choose not to be a member of an association.
Of course,
their benchmark, their degree is a standardized degree, despite the discussion around some of the biases towards strength and conditioning or sports trauma or manual therapy that do exist currently. But I know the SST are doing some work in standardizing their university accredited degrees. But there are a lot of degrees that are not accredited by the SST, who might be accredited by BASRAT, for example, sports rehabilitator and sports therapy. There are also some that are totally unaccredited. So what we're doing there, we're saying, well, if you're a graduate and you belong to this association, which I think is discriminatory, then that is the criteria by which you can diagnose. And if you don't fit that criteria, you don't meet the eligibility criteria, then you can or can't. It's how you read it.
Yeah, and to me, I think we are moving the discussion. Where there is too much effort in a discussion that actually can be moved towards somewhere else. Why do we feel that we need to diagnose? Why do we feel that we have value? Because this is what it's all about, isn't it? Let's be absolutely honest. People do not feel they have value unless they can diagnose. So it could be one, because they feel that they don't have value, and plenty to say on that. And the other one, Matt, you hit the nail in the head. Having a diagnosis or being able to provide a diagnosis gives a little bit of power. And in an healthcare where we're trying to go away from diagnosing, because, if people are really evidence-based practice, they will see that there is this big movement discussing over-diagnosing that actually is creating more of a problem. So why we person-centered care practitioners, like sports therapists or soft tissue testing, why would we want to diagnose when actually the one that they can diagnose, they keep saying, actually, we're over-diagnosis, we don't want to diagnose. When I was discussing with somebody, I said, oh, but Anna, I want to be able to say so-and-so has got a meniscus tear. Again, why? Why would you want to do that? Because when evidence-based practice is telling us that actually, just if you pick up and somebody's got, I don't know, let's say a meniscus lesion, and it is, there is no red flag symptoms there, that has to be a referral, so on. It's not that you're going to be treating the meniscus, you're treating the person. So the rehab you've been trained to be given and the treatment you've been trained to given is about the person, because actually we know that the meniscus it's very common to have over the age of 35 to have meniscus lesions. It's not the meniscus that is the problem, it's the inflammation and so on and so on. So why do we want that? Let's put the focus as in governance to actually make the vocational qualification a little bit tighter, to actually create more cohesion within the different professions, interprofessional and multi-professional. But let's go away with the fact, and actually, people always say people should do like you do, Gary, that you really show the therapist the value that they have. Let's celebrate who we are and what our role it is in the industry. It is okay if a client come to us for a long time and then they're gonna go to see a physiotherapist for an injury that you might have been able to work with them. Because actually it's okay if they want to go to a physiotherapist, not because the physiotherapist is higher trained, it's because the physiotherapist is somebody different.
But that, within our scope of practice, what we're saying to our clients and to our members is, look, by all means, have your consultation, rule out the red flags, do some objective testing, and then if you're not getting the results that you expected within 3 or 4 sessions, have a reflection and have you missed something? And if you have missed something, where might you be able to signpost? And the meniscal lesion that you mentioned, I don't think there's any harm in saying, after you've done, 3 or 4 treatments, saying, this is not responding in the way that I thought it might. Perhaps we need to go for some diagnostic imaging. And we've done some work with Vista Health since Therapy Expo, where some of our members, and at the moment their criteria as graduate members, are going to be able to refer directly for imaging. Historically, they've had a discriminatory process where you had to be a member of an alternative organisation. But they are now including us, and we're going through those. We're having to prove our, legal status and our policies and procedures, etc., with regards to qualification and membership eligibility. But it's giving us, an extra step that we can take. But be proud of what we do and recognize that actually this might be outside of my scope of practice. You're going to get the respect of the patient or the client by referring them for imaging. They'll come back to you because you've built up that trusting relationship. I think we get into hot water when we try and work outside of our scope of practice and sometimes make promises that we can't keep.
Yeah, and I like that because the STA, because you provide a lot of training, so the STA is very well trained. But even I often have to convince, the client might come back to me and they say, oh, I went to the doctor and I wanted an MRI and they didn't send me. And most of the time I have to actually reassure them and say, actually, there is a reason why they didn't, because evidence is telling us very, very clearly, only a certain level you need that. Only when the treatment will change that we need that. And this is another thing is healthcare is changing. What we know of healthcare is changing. So we should be we should not have to want to be so everybody uniform and everybody that can, that use the diagnosing term or diagnosing something really, really specific. This is where the evidence is telling us that it's not where the problem is. So I think that the focus is shifted somewhere where it's not shift, because we always we feel less good done. Instead of, the sports therapy, apart from you guys, the Sports Therapy Association, working all together to say we are a workforce, we are a professional, say we can do this, and let's all invest the money to advertise to the members of the public what we do. We seek something that actually is not really even important.
I think that's a really good summary. And that's it would have been really nice at Therapy Expo to have that conversation afterwards to open up to the audience. But the answer to that question might be, should we be, defining ourselves by our ability to diagnose, or are we missing the point with this whole question? And Mike James on the show last week, he was kind of saying, he says it's funny because he's obviously mixed in between the two worlds. And he was saying, if you've got this field and you've got sports therapists on one side and physios on the other, for example, or allied health professionals, and a fence in the middle, they can't see each other. But you've got the sports therapists on one side going, we should be able to diagnose. We want to diagnose. Why can't we diagnose? And then if they could see over the fence, they'd see most of the physios and the allied health officials going, we don't think diagnosis is so important. Why are we told we need to diagnose? We're missing the patient and everything around them and misdiagnosis and that sort of stuff. So really it's a case of just lowering that fence, which started as a metaphor, but really now we are hopefully achieving that and just talking to each other about what's best for the patient.
Mark, Tom said something, actually, he explained it much more eloquently that I was. Athletes in front of you, something that another therapist said to me this year, does the diagnosis changes how you will treat in terms of your rehab? Exactly. This is the point. This is where we're going. That for example, if we look at imaging, the current guidelines, even for NIC guidelines for sending somebody for imaging for MSK conditions, is you send them for imaging only if the results will change your treatment plan. This is why even if you have very severe, let's say you have a herniated disc, very severe symptoms, they wait for 6 weeks. They do the first 6 weeks, unless there are any red flags, i.e., usual paresthesias and bowel and blood dysfunctions. Unless there are red flags, the MRI is not called for, because we know actually that the MRI can cause maladaptive beliefs. After 6 weeks, like Gary said, if the people don't get better, after 6 weeks, if actually we know that in natural history, this particular herniation, after 6 weeks, the symptoms should be starting going down, but the symptoms do not go down, then we can, because actually risk ratio in that 6 weeks, is not very high. So, I mean, I do very much welcome about the MRI and the sports therapies, because actually after a few months, I would say it's 12 weeks is minimum, and nothing is improving, then it might be a good shout instead of having to go through the tram of NHS.
I think if we look at treating the client in front of you, and my go-to text was always Dr. Chris Norris edition, 4th edition of Diagnosis and Management of Sports Injuries, and Dr. Chris has spoke at our conferences and he's been on the podcast a number of times. His book, I used to use it as a rule of thumb. When I was planning a rehab, and it might say, we'll use the meniscal lesion, for example. It might say at week 2, the patient is expected to do this. At week 4, is expected to do this, and at week 6, expected to do that. But that's only that's guidance. Some people are going to achieve more, and some people are going to achieve less. Those people who achieve more may slow down their rehab a little bit later on. I don't think that having that diagnosis ever made, from a GP or from imaging, I don't think it ever changed my MO. I would use this protocol, my rehab continuum might change. And when I used to teach this module, exercise therapy, there was a lot of focus on progression and regression when you're prescribing an exercise. I think what the more mature therapist has built up over a lifetime is the ability to make a judgment on what exercise the person would be. I don't think somebody who was younger, 21-year-old coming out, although they've got 400 hours of placement, I don't think they might have those skills. I think that's what they're going to develop over the next 3 to 5 years. But having that skill to say, okay, I'm going to prescribe this exercise, you demonstrate, you observe and notice something that you didn't expect, you would regress that exercise. Or if the client did it easier than you expected, you'd progress it. So, that this diagnosis has never really bothered me. I just think that the grass is always greener.
Definitely. I think we've got like 9 minutes left. I wanted to also get your thoughts on the fact that, because we've had loads of guests on the show who have raised awareness of the fact of misdiagnosis. Because if you're focusing all your attention on getting that diagnosis, the danger is once you get a diagnosis and you believe in that, then potentially that's it. You've got your blinkers on and you're going to not be looking at all the other stuff. So we've had shows like, I want to raise awareness, for example, we had Deborah Hurlo-Rowley, this was going back to 2020, who was talking about how the correct diagnosis of endometriosis is currently around 8 years and 10 months, which is just shocking. It's horrible. And there's all sorts of reasons like that to do with diagnostic overshadowing and kind of gender bias and things like that. But 9 times out of 10, I suspect, I haven't got any data to prove this, that the misdiagnosis is because you're not looking at the whole person, because you have fixated on just the lower back pain and you've made a diagnosis of this or that, or you've fixated on this. So sometimes chasing a diagnosis can actually blinker you and forget to address, as we've already said, the whole person in front of you. And it's only when you look at the whole person in front of you that you can start seeing some of these other typically misdiagnoses and things which can tragically go on for about 10 years. So yeah, I mean, you've got Anna Maria Mazzieri, you do a fantastic course on red flags and things, and how important it is to address the whole person. Otherwise you're going to miss out on all sorts of terrible masqueraders. But that's something which is big on your agenda, no, I imagine, with your students.
Yeah, very, because massage therapist, and we are the ones. So when people get back, for example, I always say the one that we miss, it's the inflammatory conditions. Because when people have been feeling really stiff in the morning and they're in their 30s or 40s, where they're gonna go? They're not gonna go to the physio. They're gonna come to the massage therapist. They might not release all the information there and then, but once they're on the couch and they start to say, "Oh yes, you know what? It takes me 1 hour to actually start getting a little bit loosened up. I have to wake up an hour earlier before I can jump in the car because I'm so stiff. So I have to," and then you start thinking, oh, that is a red flag, because they will come to us first. And more now, where NHS, people that might have gone to the GP, but now the NHS is overloading, and unfortunately people are becoming disillusioned, and they actually don't go even where they should be going. So I've been screening quite a bit for people say, "Oh, actually, do you know what? I really need massage." Is never very, very, very rarely contraindicated. So I will always treat, but once they come to me, I can reassure them and say, "Actually, this is something that should be going through the GP or through the osteopath or whatever." So let's write them a letter, and they feel so much in charge and in control. There is a client that stays with you then forever because they know that you are doing what you're doing for their best. So for me, red flags are important because we're missing them. We are, and it's not the codequina that we're missing. We're missing those subtle ones that we should not be missing. We're still too worried about when people tick the box cancer on their consultation form. Massage is not, or sports therapy is not contraindicated for cancer, but what it is the person that comes to you is because they got pain. Is the pain coming because of MSK issue, or is the pain hiding something be more sinister? That's what we need to be focusing. So knowing more about those red flags, knowing more about those contraindications, because somebody said, yes, one of the comment that they made, was, "We do so many hours, we are the sole qualification that should be assessing, we are the sole qualification that has as much hours in MSK injuries, and therefore we should diagnose." And my query will always, yes, they say they got more hours than physiotherapists, but actually, if we only do MSK, we only see MSK. When actually, if you look at chiro and osteo, they don't only do MSK, they do many more broader, and at the same physiotherapist, broader curriculum. That broader curriculum actually gives you ability to critically put together certain condition differential diagnosis, that if you only do MSK, there is, yes, you might know a lot about a meniscus, but what about if it's
I think one of the things that's become apparent over the past decade is that the value of a consultation form, and I've discussed this with the insurance underwriters recently. If if we send out our, online consultation form, have you had a history of heart disease, cancer, surgical interventions, etc., we were presented with a yes and no sort of answer sheet. I don't think that elicits the type of information we want. So if we use the Gary Mendoza, Daniel Williams sort of methodology of a sort of an interview, and if I had a client come in to see me today, I would get them to fill out the the consultation form, because that's an insurance requirement. But I'd just say, then, I'm going to sit here for 10 minutes. I want you to explain to me everything that you think is relevant, your past medical history, what you think is relevant with your, whether you're getting nighttime pain, whether it's pain in the morning, what exacerbates it, what makes it easier. And then having that supplementary information makes it a lot easier to make that clinical judgment earlier on. And I'm an advocate of having an extra box on your treatment card saying supplementary information provided, because it's amazing how many people forgot they've had a stroke or a shoulder replacement operation until the fourth or fifth treatment. So get as much information as you can. Have a sort of a conversation rather than a consultation, because we're going to get the right amount of
have a conversation instead of a consultation. That is so beautiful, Gary. Have a conversation instead of a consultation. That is fantastic.
The other person then feels more involved anyway, don't they?
Yeah.
Good advice.
Because that's what we know from narrative medicine, that the healing is in the story. The healing is in the narrative of the story. If we allow them, like you say, spot on. Yes, I am having the consultation form. I like to send them before, because I want them to start reflecting already. It's a sense making process for the person in pain to start writing down it. But even the consultation can be written in such a positive or non-threatening ways, and also like questions like, is there anything else you would like me to know about your health? And then when they come in, I often say, I already read the form that you I want to hear it from you. I want to, and then you start that conversation. I can't tell you how powerful it is, the word that you use there, conversation, and not a consultation. I've been trying to find always a substitute for subjective assessment, but Gary, I will quote you, but I will call it initial conversation, not initial interview, because an interview, again, initial conversation. That's it, Gary. You sorted out my conundrum.
10-year dilemma.
Thank
Fantastic.
you. Can I just cover the insurance aspect of this, Matt, as well,
Yes,
please?
certainly.
And Brian's alluded to it there. If we were allowed to diagnose, that gives us a greater sense of responsibility. Now, what I have to do, and this is why I spend too much time talking to insurance underwriters and Balin's Insurance, is to understand what can go wrong and understand, when your insurance may be cancelled or may be void. And if we're working outside of our scope of practice, what we have to do is we have to look at what's called our overarching qualifications. That's your highest qualification in this industry-specific sort of subject. And then all of the modules on there are your scope of practice. If you have done CPD, and I'm going to use an example, if you've got a level 3 qualification that was issued after 2014, but your training provider has sold you a dry needling qualification, then that is not in your scope of practice, because it's the application of pre-post intra-event massage and maintenance massage. Dry needling has a remedial intention, therefore you need level 4. But your overarching qualification, what makes you insurable, CPD, is considered underneath the overarching qualification. If I found myself in court, and this is just an example, where I had caused harm to somebody, then what the judge will look at is whether I've overstepped my scope of practice. And I will have to prove through my note writing what I've done. And that's why it's important to have comprehensive notes written down instead of just a few abbreviations, because up to 7 years' time, somebody can claim against me, and I need to know exactly what happened in that session. So it's important that we write good quality notes. We are going to be doing a special podcast with a guest who I'm just trying to confirm on using artificial intelligence to collate notes. and also record the conversation and highlight the salient points from that. But what we don't want to be doing is overstepping our scope of practice, because that's where we will find ourselves in hot water.
Just because
Great, good advice.
we think we can do something, we shouldn't. One of the things is, for me, working with with children. Unless you're trained for it, don't do it. They're not. And this is where the most out of scope that I do see around, actually, working with young children, or missing red flags, big red flags.
Fantastic. Great information, guys. And I think, to conclude, because I mentioned earlier that sometimes we try and use word diagnose to elevate ourselves and make ourselves more powerful. We've had so many guests on the show, physios, surgeons, hugely respected educators, saying the power we've got is the time, particularly working in the private industry. We've got that time to establish such an amazing alliance with our patients, particularly if there's touch involved. If they enjoy that, then they're going to peel off the layers so well that we become hugely important in the circle of care for them, in them revealing things to us and allowing us to potentially signpost them to somebody who can diagnose. So in actual fact, we've got a beautiful power. If you're a non-allied health professional, you've got the power to be able to help that person without running the risk of diagnosing and getting it wrong. Yeah, if you can signpost somebody who you suspect might have endometriosis or hypermobility or Ehlers-Danlos syndrome or male pelvic health issues or any of these things which we've learned through good CPD could be happening, refer them on to somebody who can take that burden on their shoulders now. You've done your job in signposting. It might not be right, but at least you've helped that person potentially get diagnosed. And I think that's where our power needs to lie. And if you recognize that, you don't worry about diagnosis. That's not our role. Our role is to use the fantastic skills we've got of listening and helping our clients feel safe and non-judged, and tell us what's wrong with them, what they think is wrong with them, and forward them on. That's our power.
I think it's also important, Matt, to consider, to reconcile with yourself as a therapist what your treatment is actually doing. If you're applying massage to support somebody who's had a recent cancer diagnosis and is suffering from stress and anxiety, then it can be really beneficial. I've worked with quite a few of my patients who went on to develop cancer, and the support that we were able to give them whilst they're having their treatment, we're not treating the disease, we're managing their symptoms and supporting them through what is a really stressful journey.
Very good.
And also, the last is that for those of you that are not university trained, it's, please do not feel, if university is wonderful if you enjoy the academic learning, and if your brain, you like the very analytical, superb, I love it. But if you're not, from a clinical perspective, in fact, going to university taught me that in our profession, we don't necessarily need a university degree as long as the vocational training. So you don't feel that you are any less. But we need, in vocational training, we need to be more, like Gary said, more reflective, less modality and more reflective.
Fantastic. Wonderful summary. Right, look at us, 9:05. Hopefully that's been a useful discussion. Thank you, everybody who joined us live. I really appreciate your questions and input, everybody. And if you listen to the podcast, like I say, if it made you think and you want some more information or leave comments, then go to YouTube and leave them on there. We don't want this subject mustn't just end tonight and last for a week. It's an ongoing thing. This is still going to be relevant in half a year, 2 years down the line. So do what any you watch. If you're listening to this, go to YouTube and leave a question and keep the conversation going on this topic and all the other topics we've got there. Next week, let's just go back to showing a little picture here. Next week, we're going to have our Christmas party. 2025, Christmas 2025. And we're going to have members from the STA, from all the hard-working admin team and champions and podcast hosts and all sorts of wonderful people who are going to be having a look back at 2025 and ahead at 2026. So it'll be a great time for you to come along and join us live if you can. Not only STA members. It was a really nice opportunity if you're not an STA member to come along and listen to what we have done, how we've supported you, what our plans are for next year to support you, because that's why we're here. We're here to support you. It really is. We're a non-profit association who is trying to help the industry and help you guys. So do come along and hear how we've done that and what our plans are for next week by coming to YouTube or Facebook at 8 o'clock. And you can join us for the Christmas 2025 episode. I nearly put Winter Festival or something. I really am conscious that not everybody does celebrate Christmas, but it was just looked too long and windy. But I appreciate not everybody does celebrate Christmas, and I respect that. And if you just want to come and celebrate the Winter Festival with us, then that's great. Or if just December, whatever reason, come along and join us for the holiday festivals. My thanks once again to Anna Maria Mazzieri for giving up your time and experience. Thank you so much, Anna Maria. I hope this has allowed you to express what you wanted to when you put your hand up and got 25 seconds at the end of the panel debate.
I picked up then with Laura Fino came after, and I said that was a little bit unfair.
It's tricky. I think this is the feedback for Therapy Expo, isn't it? If you're going to have an incredibly amazing panel debate like that, you've got to plan in at least 10, 15 minutes for reflection afterwards, for questions, for the, because it's going to help everybody who listened to it take it home better. So we'll take that to the next year because it was great.
Let's remove this elitism, this is the thing. I want everybody, just because they're academics.
Yeah. No, definitely. Because the most important viewpoint in that whole theatre, it was lovely having the 3 people on stage, but let's turn that camera around to the 100 people watching. What do you think? That would be really useful, I think, for the speakers as well.
It was a great panel, though, I have to say.
It was an amazing panel, and seeing them all together was great.
It was not very.
Gary, we'll talk about this next week on the show, looking ahead at 2026. But it was a great panel, was it? You must be the most cynical person in the whole of our industry, because you've seen it all. You've seen people ripping your name apart, but now do you feel if you feel optimistic, then we can all feel optimistic. That's what I'm saying.
Yeah, I do, recognise that I have been a thorn in the side of many an industry stakeholder over the years, but the intention has always been the same: is to get people talking, get people round a table, and for the first time in 15 years, that's happened, and I want to publicly go on record by thanking the SST and the STO for agreeing, and in the SST for organising our collaborative meetings.
Without a doubt. And we will have them on the show. We've been speaking to them, and the collaboration will continue. It's going to be the word to use in 2026. We're really looking forward to having members from the different organisations, associations on the show, so we can have some real great conversations. That's what it's all about. It's all about communication, not just with our patients, but with our colleagues in different associations and organisations and that. So if you have enjoyed this episode, as always, please subscribe to the YouTube channel. This appears high in Google search results if you leave a good rating and a review. So please do that. You'll be helping the industry loads by doing that. And if you are interested in joining the STA, then just to remind you, you can use the code podcast25 and it'll get you 3 months extra if you join for a single year. So instead of £75, yes, I repeat that, £75, you will get 15 months instead of the normal 12 months for that £75. And it's only valid for new members. And if you're level 3 and qualified after 2014, then make sure you opt for associate member when you join up. There we go. Right. Thanks again, Anna Maria Mazzieri, Gary Benson. Thanks so much.
Thank you for inviting me.
Hopefully see some of you next Tuesday at 8 o'clock. Until then, take care of yourselves and each other. Bye-bye.